My name is Shah. I'm a radiation oncologist at the Cleveland Clinic. I serve as the Director of Breast Radiation Oncology, as well as the Director of Clinical Research in Radiation Oncology. Adjuvant radiation therapy in early stage breast cancer has undergone a dramatic revolution in the past 2 decades. With the conception of breast conservation more than 30 years ago, women routinely underwent lumpectomy followed by adjuvant radiation. Adjuvant radiation in those studies consisted of whole breast radiation delivered over 5 to 6 weeks, often with a tumor bed boost for another week and a week and a half. This led to excellent outcomes, but also led to opportunities to improve, as many patients were unable to undergo 6 to 7 weeks of daily radiation therapy. Also, patients who were far distances from radiation centers may not have been able to receive breast conservation due to this issue. In terms of whole breast radiation, we now have multiple randomized trials with 10-year or greater follow-up, demonstrating the benefit of hypofractionated whole breast radiation. Hypofractionated whole breast radiation allows for the completion of radiation in 3 to 4 weeks as compared to 6 to 7 weeks with standard whole breast radiation. Multiple studies have also confirmed that there's no difference in outcomes with respect to local control or survival with this technique, and comparable toxicity and cosmetic outcomes as well. Similarly, partial breast irradiation has emerged over the past 10 years, allowing for women to not only complete treatment in a quicker fashion, but also potentially reduce toxicities by decreasing the volume of treatment. Partial breast irradiation can be performed in multiple ways, including interstitial brachytherapy, where catheters are placed into the breast, applicator brachytherapy, where balloons or other devices are placed into the lumpectomy cavity, or using external beam techniques. Currently, 8 to 10-year data is available from multiple randomized trials, confirming low rates of recurrence with partial breast irradiation, and depending on the technique, comparable or reduced toxicity outcomes. Of note, partial breast irradiation delivered with three-dimensional conformal radiation has been shown to be associated with worse cosmetic outcomes, though no difference in local control has been noted. With respect to patient selection, hypofractionated whole breast irradiation can be offered to all patients with early stage breast cancer following breast conserving surgery, with the addition of a boost based on risk factors including age, receptor status, margins, grade, and lymphovascular space invasion. With respect to partial breast irradiation, guidelines recommend the use of partial breast irradiation only in patients aged 45 to 50 or older with tumors less than 3 centimeters. There is some variability in partial breast eligibility based on receptor status, with some guidelines supporting partial breast only for estrogen positive patients, while guidelines such as the American Brachytherapy Society allowing for partial breast and estrogen receptor negative patients. One final partial breast technique that can be considered in some patients is intraoperative radiation, allowing for the completion of radiation in a single treatment at the time of surgery. At this time, however, both the ASTRO and American Brachytherapy Society guidelines do not recommend intraoperative radiation outside of prospective trials, with the exception of a suitable risk cohort, which may be appropriate for electron-based intraoperative radiation.